Hello, welcome to Pancreatic Function and Gastrointestinal Function. We're going to talk about some of the different things that the GI system does, especially the pancreas. A lot of my students think I'm crazy that my absolute most favorite organ in the whole entire body is the pancreas. I am completely amazed at how much this little guy secretes in a given day and what these secretions actually do for a person on an exocrine level, which could be like the enzymes and such, and an endocrine level, such as the hormones that it secretes. It has so many important pieces to the digestive puzzle that it's just, you couldn't survive without it. And we're going to talk a little bit about pancreatic cancer too, and why that becomes so deadly, and how impossible it is to live without this organ that you don't hear about very often. So when we talk about the GI system, we're talking about the mouth, the esophagus, the stomach, and the small and large intestines. The definition of digestion is the process by which the starches, proteins, lipids, and nucleic acids are degraded to molecules for absorption and use in the body. So as you can imagine, when you eat a steak, or let's say a hamburger, because that has all of this in it, it's got starches in the bun, it's got protein in the burger, it's got lipids with fats in it and the cheese and such. When you eat that, it obviously needs to be broken down into smaller pieces, such as amino acids and sugars and things like that. So that's why we need the digestive system to work appropriately in order to get those nutrients into the body. Well, the pancreas plays a very important role in the GI system. It actually secretes things that are used for digestion and also helps break down food products. It's a very large gland involved in the digestive process, lays just outside the GI system, and on the next slide I'm going to show you a picture of where that sits. But it's located behind the peritoneal cavity across the upper abdomen at the level of the first and second lumbar vertebrae, just above your umbilical cord, or where your belly button may be. We have both endocrine and exocrine components of that, and I am going to go over both of those so you know the difference. So here's the abdominal structure of the alimentary tract, or the digestive system. And you can see the pancreatic duct here. So the pancreas kind of sits across where I'm drawing this circle. And it puts its exocrine products into the duodenum that you see by way of this pancreatic duct. As you can imagine, it's right next to the bile duct right here. So when you hear people getting gallstones or something like that, it sits very close to the pancreatic duct. So what can happen sometimes is bile fluids can end up in the pancreatic duct because they're so close, and that reflux of that causes pancreatitis or an inflammation of the pancreas. You may have heard people say they've got pancreatitis, very painful, but those bile acids and things can actually reflux up into that pancreatic duct and cause an inflammation, which is very uncomfortable. All right, we're going to start with the endocrine component. It's not as big as the exocrine component, but it is still quite powerful. It consists of the islets of Langerhans. That's always fun to say. It has different things that it secretes into the blood via hormones. The first one you've heard of, because we talked about it in our carbohydrate chapter, is insulin. We need insulin to get the glucose into the cells. If you don't have insulin, your blood sugars just get higher and higher and higher, but the cells can't get at it. The next one is glucagon. This one increases the amount of glucose in your blood. Let's say that you're running a marathon and you've used up all your blood glucose. It's actually capable of grabbing those glycogen stores and turning them into glucose in your blood so that they're readily available for your cells. Gastrin is also very important. It stimulates gastric acid secretion to help with your stomach and the digestion to break things down. And I'm going to skip down to secretin here because somatostatin inhibits secretin, but what is secretin? Secretin causes the production of bicarb-rich pancreatic fluid, which protects the lining of the intestine from damage. Okay, so everybody knows you have stomach acid. It's very acidic. You've maybe heard stories of people that are bulimic, and it actually causes ulcers in their esophagus. It wears away at the enamel on their teeth. Some teenagers that go to the dentist, that's how the parents find out that, a teenager may be bulimic, is by seeing the enamel worn off the teeth from the excessive vomiting. So really acidic stomach. Well, if you had all that acid dumping from your stomach into your intestines, it may cause some damage. So the secretin causes the production of that bicarb-rich fluid, which kind of buffers out that acid, or makes it so it's not so acidic. You're adding an acid and a base, so it's kind of neutralizing that pH, so it can better be absorbed, and your intestines could handle it better. The next thing, and somatostatin inhibits that because you don't want too much of it. Cholecystokinin, in the presence of fats and amino acids in the duodenum, it's produced by the intestinal mucosa and is responsible for enzymes from the acinar cells in the pancreas by increasing intestinal motility and gallbladder contraction. So you need your intestines to be able to move things through it, but you also need your gallbladder to contract to get some more of those types of agents in there as well. The last one I'm going to talk about here is vasoactive intestinal peptide, and he relaxes smooth muscle in the gut and increases the water and electrolyte secretion because you need a certain amount of fluids to be able to handle digestion as well. So next is going to be the exocrine component. The endocrine is more of the hormonal things, but exocrine refers to the digestive fluid, which is rich with enzymes. It lines the pancreas, and it's released in response to gastrin. So it does secrete all kinds of fluids. And what really amazes me is the fact that it secretes 1.5 to 2 liters of fluid a day. So if you think about it, I've got 2 2-liter bottles of soda down here. That is how much fluid is secreted into the duodenum every day. It's hard to imagine. It goes to show you how much reabsorption happens back into the body. We do have some diseases of the pancreas that I'd like to cover. First one's cystic fibrosis. This is an inherited autosomal recessive trait characterized by the dysfunction of mucus and exocrine glands throughout the body. This is usually occurs when the mom and dad both have some type of a recessive gene and come together and create the actual expression of cystic fibrosis. Some of the things that happen with these patients, they have excess mucus that helps prevent proper absorption through the intestines. Sometimes they have a lot of mucus in their lungs. If you've ever known anybody with cystic fibrosis, they do have some breathing treatments that they do from time to time. It can be very uncomfortable, and they can get more infections than other people as well. Some of the things that can happen in newborns: intestinal obstructions, excessive pulmonary infections. They do get a lot of coughing and things like that. And the pancreatic malabsorption in adults becomes a problem. I've drawn a lot of blood in the cystic fibrosis clinic in Green Bay. A lot of them are very thin. They're watching their nutrients very, very carefully. So one of the tests that we can do, this one's a little bit outdated. We probably do more genetics testing now. But even up to 10, 15 years ago, the lab that I worked in Green Bay did sweat chlorides. So what they do is they take a little, it was like a little sticky pad that had an electrode in it, and they would tape them to the child's skin. There's a baby up in the top here getting this done. And they would collect the sweat in these little pods that were stuck to their skin when they applied a small current of electricity to cause them to sweat. And what we would do is we would test the sodium and chloride levels in their sweat. If it was above 60 millimoles per liter, we could diagnose them as having potential cystic fibrosis. What you need to know about this is the sweat collection involves pilocarpine administration by iontophoresis. You need to know that. Next one, pancreatic carcinoma. It's the 4th most frequent form of fatal cancer. The 5-year survival rate is less than 5%. You can see Patrick Swayze, how he looked with his Dirty Dancing movie down on the bottom left-hand side, and then how he looked within the weeks before he died. As you can see, your pancreas is very important. It helps provide a lot of absorption and nutrient absorption, things like that. And if you're not able to do those things, of course, you're going to waste away very quickly. And he was almost unrecognizable at the end. Most of the tumors arise as adenocarcinomas of the ductal epithelium within the pancreas. A next issue, not so much a disease, but it could become a problem, is pancreatitis. as your word parts show you, it is inflammation of the pancreas. I talked about this a little bit earlier, but this is caused by the autodigestion of the pancreas as a result of that reflux of the bile or duodenal contents up into that pancreatic duct. Some of the things that we see in these patients would be acute edema, which is like a swelling or a fluid in the tissues, cellular infiltration, and intrahepatic and extrahepatic pancreatic fat necrosis if it gets bad enough. The big thing that we see as laboratorians is a very increased amylase and lipase. When you see amylase and lipase, put those with pancreatitis. So all three conditions can result in severely diminished pancreatic exocrine function, compromising digestion and absorption. Pretty much any pancreatic issue can do that. One of the other issues we have is that malabsorption syndrome that we talked about. If you cannot absorb things very well, this cystic fibrosis can sometimes have these issues as well. Abdominal bloating, discomfort, frequent passage of bulky malodorous feces, and weight loss. If you're not able to absorb those fats, they will end up going right through you. Another test that we can do to see how the pancreatic function is working is a secretin CCK test. This is quite invasive, and this would be kind of a last-ditch effort if they're trying to figure out what's really going on. What they do is they intubate your duodenum. I don't know if they go probably up through your nose, down into your stomach, and into the duodenum, or they could probably go through the outside of your stomach. I'm not 100% sure. But what they do is they go into the duodenum and they collect the pancreatic secretions over about 6 hours or overnight. And then they stimulate secretin, and they also give CCK. They collect the secretions for 30, 60, or 80 minutes after administration. And then the secretions that they get would be sent to the lab where we would measure pH, secretory rate, enzyme activities, and bicarbonate just to make sure the pancreatic function is okay. Another less desirable thing that we do is a fecal fat analysis. If you have fat in your stool, it means you probably have a pancreatic issue or a malabsorption issue. So that's why they would go and do further screening. But the first thing that we would do is to see if they actually have fat in their stool. When somebody does have fat in their stool, it's usually very foamy. It's very, very odorous compared to other stool that you may get in the lab. Usually the fecal lipids are derived from one of four sources. You could have unabsorbed ingested lipids. You can have lipids excreted into the intestine, cells that are shed into the intestine, and the metabolism of just intestinal bacteria that die off. The easiest test to do is a Sudan stain. Fats and other lipids stain yellowish orange to red with Sudan dye. What you see in the picture here is a stool sample. The bright orange that you're seeing is the fat globules staining with Sudan dye because that is lipid soluble. If we see an increase in fats and undigested meat fibers, it could mean steatorrhea, which is fatty stool. This word steatorrhea is fatty stool of pancreatic origin. So let's say we do see some fat, or the doctor just wants to know exactly how much is there. We can do a quantitative screening if he wants to know. I don't know exactly how much fat is in that stool. This is the job when some of my friends did a internship at Marshfield Clinic in Wisconsin. It's a very, very large lab. I compare it to Mayo Clinic, the Wisconsin's version of Mayo Clinic. And they had a department that this is all they did. So what they would do, the patient submits a 72-hour feces specimen. So they have to essentially poo in a large container for 3 days straight. What they do is they take that whole stool, they put it in this blender that you see in the top right-hand side, and they emulsify it with water. So you add some water, you hit frappe, blends it all up. Then an aliquot is acidified to convert all the fatty acid soaps to free fatty acids. Those lipids are extracted into petroleum ether and ethanol, and all the residue comes to the top. They take the residue and they weigh it. They can tell the physician then out of how many grams of stool, what percentage of it was fat. This is the best test to diagnose malabsorption. Once again, excess fat in the stool is called steatorrhea. Now, you don't have to memorize these steps, but do know that the gravimetric method tells you is more specific than just a Sudan dye. Coming back to these enzymes again, we talked about amylase and lipase with the pancreatitis, but amylase is probably the most commonly used one. It's very useful in acute pancreatitis. We also find it in saliva. It helps break down things as early as the mouth. Serum levels increase within hours of the onset of disease. They get pretty high within 24 hours, return to normal in 3 to 5 days. Normal range 26 to 102. Pancreatic patients I've seen in the thousands and thousands. Some physicians think that lipase is more sensitive than amylase because it elevates about the same time, but it stays elevated much longer, 7 to 10 days. Kind of reminds me of the troponin for a heart attack. That's how the lipase is for pancreatitis. Normal range about 10 to 73. Again, I've seen these in the thousands as well. Some other things that we can do, things that trigger gastric secretion. We've got neurological impulses from the brain. Distension of the stomach with food can cause gastric secretion. Contact of protein products with the gastric mucosa causes gastric secretion. And then we have the hormone gastrin. He is the most potent way of getting more gastric acid secretion in the stomach. Now, when you have plenty of gastric acid, you need to slow it down. So we have some inhibitors. Some things that'll stop the gastric secretion would be just having a high gastric acidity. That will decrease the amount of gastrin. Gastric inhibitory polypeptides secreted by the K cells help suppress that. And the vasoactive intestinal peptide will decrease your gastric acid secretion as well. So some of the purposes of gastric analysis may be to see if they have some disorders of a gastrointestinal origin. One of the things that I have not seen a lot of in my days in the lab, but could happen, is Zollinger-Ellison syndrome. These patients have a gastrinoma that secretes tons and tons and tons of gastrin. And as we just learned a few slides earlier, gastrin causes the increase of gastric acid secretion in the stomach. Well, if you have a gastrinoma that's secreting and secreting and secreting and secreting and secreting, you end up with ulcers, severe ulcers, very painful, also diarrhea, having a hyperacidic situation. So sometimes they have to do a surgical procedure to try and find the gastrinoma and treat those ulcers. One of the other things that they can do to see if there's a gastric acid secretion issue or if they need excess gastric secretions is to give them pentagastrin. All right, let's look at digestion just in general, moving on to the intestines here. Digestion is predominantly a function of the small intestine. It's necessary to absorb most food molecules. So here's what happens, and this is just blows my mind, just like the pancreas secretes things. 7 to 10 liters of ingested water, food, and secretion from salivary glands, stomach, pancreas, and biliary tract enters the duodenum. That's like 5 of those 2-liter bottles of soda, of things that enter that duodenum every day. The materials that enter the jejunum and ileum, where 1.5 liters of secretion is added, only 1.5 liters of fluid actually reaches the cecum, or the next point. The mucosal folds, villi, and microvilli in their 20-foot-long small intestine allow massive reabsorption of all of this water, etc. So the large intestine absorbs water and stores feces before defecation. So that's how you hang on to your water. That's why you become so dehydrated when people have diarrhea. We do have other diseases that can cause malabsorption. Celiac disease you may have heard of, which is where they don't have a lot of, we're going to get to that in a minute, but they can't handle gluten very well. Whipple's disease, Crohn's disease, having a lymphoma, intestinal resection where they take some out, lymphangiectasia, which is they take out some lymph glands, ischemic bowel is essentially a dead bowel, amyloidosis would be like a scarring, and giardiasis would be a parasite. Another thing that you've probably heard of is someone who says they're lactose intolerant. They're lactose intolerant, they can't handle things like ice cream and milk. They're deficient of an enzyme called lactase. You need lactase to break lactose down into glucose and sucrose, etc. People that do not have lactase experience abdominal discomfort, stomach cramps, and diarrhea after ingesting milk or milk products. It's said that 10 to 20% of white people and 75% of African Americans are actually lactose intolerant. So the lactose tolerance test it helps us determine if they could potentially have this, but we do find a lot of false positives and false negatives. They can also do a hydrogen breath test to see if you're positive. You may have heard of lactose-free milk, and that is where they add these kind of like lactate tablets. It has lactase in it already, and so that lactose is already broken down for you before you drink it. Another test we can do to see if you have either a malabsorption from your intestines or a pancreatic issue is a D-Xylose Absorption Test. D-Xylose is a sugar that's not ordinarily present in the blood, but they're absorbed unaltered right into the bloodstream. So what they do is they have you fast overnight. You come in the morning to the doctor's office, you go potty, and you drink a D-Xylose solution. Don't ask me what it tastes like, I have no idea. You drink equivalent amounts of water during the next hour, and then they collect your urine for 5 hours after ingestion. And they also collect your blood. If the D-Xylose is absorbed through into your bloodstream and is found in your urine, you do not have a malabsorption issue. If it is negative from your urine and your bloodstream, it means that you have a malabsorption problem. Things are not making it through the intestines. Another fun disease of the digestive tract, not so fun if you have it, but it's very interesting, the history on it, is H. pylori or Helicobacter pylori. In this case, there's actually a bacteria that invades the stomach and causes ulcers. Now, there's a guy back in, oh gosh, I can't tell you what year it was, quite a while ago. I want to say in the 80s or so. I think he was from Russia. Or does it say Australia on there? Anywho, his name is Barry Marshall. And he said that you could treat stomach ulcers with antibiotics. And everybody thought he was totally crazy. So what he did is he took a whole beaker full of H. pylori and drank it. Got incredibly ill. So then he gave himself a whole pile of antibiotics and proved to the world that, sure enough, there is a bacteria causing these stomach ulcers, and it can be treated with antibiotics. So it kind of caught a lot of attention at that time. So he is the crazy doctor who gave himself an ulcer and solved a medical mystery. Kind of interesting. This used to be done, we do a urea breath test. We can do an enzyme immunoassays, very quick and easy. Or we can do a stomach biopsy called a CLO test, which where they go down in the stomach and they take a little piece of it. And CLO stands for Clostridium-like organism, which is what they're looking for in some type of media. So back when I worked in the lab, the CLO test was the most popular. They did it in the GI lab. Now, enzyme immunoassay, they just do a blood draw, and they're looking for antibodies to H. pylori. All right, celiac disease is another one. This one is becoming increasingly huge, actually, in the United States. They're finding more and more people have celiac disease. And this is an autoimmune disorder produced by the ingestion of gluten. Now, there's different levels of this. You can have an autoimmune disorder where you have severe reactions to gluten, or you can have an intolerance to gluten where it actually produces other issues within the body. Celiac, severe celiacs, if they eat it, they get severe diarrhea, they get sick stomach cramps. Other people who may be in a celiac type of category may have other issues happen. They may get sick more often. They may have eczema. There's a big correlation between eating gluten and having eczema. They may have other thyroid issues. Hypothyroidism and things like that can be caused from excess gluten ingestion. I know that I have Hashimoto's, which you guys have heard me talk about before, and when I take gluten out of my diet, my thyroid function increases dramatically because of the autoimmune issue. So I am gluten sensitive. I wouldn't put myself in a celiac disease category because if I eat it, I don't get diarrhea or anything like that, but it does cause eczema to pop up and my Hashimoto's to get worse. The next one's kind of fun. This is serum carotenoids. Serum carotenoids are found in various fruits and vegetables. Major carotenoids that you may have heard of: lycopene, xanthophyll, beta-carotene, etc. These are fat soluble, and if you are to absorb these, you have to eat fat with them. Okay, so if you were to just eat these vegetables on their own without any fat, you wouldn't absorb very many. So what they do is, if you're eating a normal diet, they'll draw your blood for serum carotenoids. If they're very low, it could mean that you have a malabsorption of lipid issue, because you need lipids to be able to absorb those. So if you can't absorb lipids, you're not going to absorb the serum carotenoids either. So therefore you would have a low level. Other tests of intestinal malabsorption, people have a diminished appetite, dietary intake. We see them wasting away or having cachexia, which is a severely anorexic look to them. Negative nitrogen balance, decreased serum proteins and albumin because they're not able to absorb those. We can see a deficiency of those fat-soluble vitamins like the carotenoids, vitamin A, D, E, and K. We see deficiencies of vitamin K, anemia, decreased iron, calcium absorption, decreased sodium, potassium, dehydration. In general, they're going to look pretty bad and they're going to feel pretty bad. That concludes the section for the pancreatic function.